about the challenges. So the most important part is that pancreatic cancer is actually only cured when you do a resection. And even in stage 1 disease, if you do not resect, you won't cure. I think this is very important to have in mind. And we know from the old data here from the United States from 1995 to 2005 that in about 50% of all cases, treatment is not offered, and especially surgery was not offered to the majority of patients. And that has not changed much, because if you look at the latest data, and that is an international series, you see that even now in the United States, but even worse in the Netherlands, the resections performed in stage 1 and 2 disease is less than 50%. So the main challenge for us is to advocate the role of surgery to colleagues, medical community, and the public. And let's actually face the main goal is we want to resect the cancer. We just heard about what kind of cancers are resectable. We are definitely in the palliative setting when we have distant metastasis, but everything else might be resectable. Have in mind, borderline resectable means you can technically resect the tumor. And by this we have 50% of all cases, almost 50% of all cases diagnosed have local disease only, and therefore might benefit from surgical resection with or without neoadjuvant treatment. So the challenge number 2 is extended resections and vascular reconstructions can be performed safely, but that can only be performed safely in centers. So centralization is a big challenge, and that is very different in different countries because of the health systems. So in Germany, for example, still 50% of the pancreatic cancers are treated in hospitals which perform less than 10 resections per year, and the mortality rate is enormous. And the next challenge here is, how do we train young surgeons to become successful pancreatic surgeons who can actually do extended resections? Because you not only need to be able to resect the pancreas, but you also need to be able to resect the colon, the stomach. You need to be able to do vascular surgery. And there again, you have national differences. Depends on how often you are in the operating room. Is it once or twice a week or every day? How long is the training and so on? So every country has its homework here. We do know that pancreatic cancer is approached in a multidisciplinary way, and the gold standard is resection plus adjuvant treatment. And we have excellent results from the SPAC4 trial. 40 months median survival, 5-year survival, 40%. We do have the FOLFIRI-NOX data with 54-month median survival, and 40% of those patients were actually resected R1, and still the results are excellent. So gold standard, resection plus adjuvant treatment, but of course we have advanced cancers, the borderline resectable and the locally advanced, where we need to do some pre-treatment. At least we think. So what is the potential gain of neoadjuvant treatment? We want to avoid the progress of the systemic disease, increase resectability, especially the R0 resection rate, increase the long-term survival, and select the right patients. But can we do this with the drugs we have at the moment? And if you look at the response rates of chemotherapy, no matter which drug you're looking at, you have response rates of 30%. And the same is true for radiochemotherapy. So the response rates are low. And if you look at this, the major pathological response is probably expected in 13% of the cases. In those, patients do very, very well. 73 months median survival, that's great. But what about the other 90%? And do you know whether these 10% would be those who profit more in the adjuvant setting as well? Because it's a biological effect you may have in the adjuvant setting as well. And those who respond well are young patients with the lowest CA99 and who are treated with gemcitabine-based radiotherapy. I don't want to go over this in too much detail, but systemic reviews show here 3,500 patients that the resection rate is lower when you treat in the neoadjuvant setting by 20%. And we have 4 randomized trials out there now, and they also show the resection rate is lower, but the R0 resection rate is higher, and the median survival is not that great. The best given in those randomized trials is 36 months, and we have looked at those data in more detail yesterday. So resection rates are lower when you treat neoadjuvantly in resectable or borderline resectable tumors, and the survival is a little better when you treat neoadjuvantly. So at the moment we have the questions, do we have the right drugs? What treatment should we use? What combinations? How long should we treat? And when do we do the surgery? We have a special problem in older patients because they do not take neoadjuvant treatment well, especially not the more aggressive forms. So this series of cuts that all show that the resection plus the adjuvant treatment, or even without the adjuvant treatment, the older patients do quite well compared to the neoadjuvant treatment. And you have to have in mind that in old age, people do not get resected after neoadjuvant treatment in over 50%. So you have to really think about neoadjuvant treatment in older patients, and you have to, again, think that surgery is a major cure, potential cure for pancreatic cancer. So locally advanced primary unresectable disease, you have a problem because you do not really reliably know whether it's going to be resectable or not. Have in mind 30% of the patients respond to neoadjuvant treatment or chemotherapy and radiochemotherapy. So clinical performance, imaging, tumor marker are not really reliable. So in general, we do a surgical exploration. And we do now this from the FOLFIRINOX data, where we see resection rates of 30%, so 30% respond to treatment. And we have similar data from systemic reviews, which are a little older. 30% can be resected when they are locally advanced and unresectable in the first place. Here are old data from Heidelberg, where we saw the same thing. 30% are resectable, but then the median survival is only 24 months. So the advanced stages do worse than what we know from the small cancers. So the challenge is here, when do we do the surgical exploration, and how do we do the decision when to actually operate those patients? And that needs to be done by a pancreatic surgeon, and we need to be involved. This is probably the most important part of my talk. We do know that tumors do not shrink concentrically after neoadjuvant treatment. It's a patchy process, and there's a great diversity in different areas of the tumor. So when we have neoadjuvant treatment in locally unresectable disease, we may have something like this. So first of all, we have involvement of the SMA and the portal vein, but then the tumor shrinks even on the imaging, and we do a nice Couch-Whipple procedure and a vein resection, and we are happy to see an R0 resection in the pathology result. But is that really a R0 resection? Because we leave in some of the tissue which was involved before. To make that point even more clear, look at this one. This is a big tumor involving the SMA and the supramesenteric vein. The tumor marker decreases, but in the exploration you do not know what to resect, because is it scar tissue or is it still tumor? It's not concentrically decreased. So we did complete total pancreatectomy with resection of the colon, stomach, and the SMA, and replaced the SMA distally into the aorta. And this was a close margin, and also the neoadjuvant treatment was performed for almost a year. It was a low regression rate in the histology, which is also a point we do not know because regression is very difficult to diagnose and to deal with. So arterial resections, and we just had that topic in the last talk, need to be performed in advanced cancers. And I think the rationale for doing this is small arteries are always resected by any surgeon when you resect a pancreas. The splenic artery is always resected in left resections, and nobody even thinks about it, whether the artery is infiltrated or not. So it's a technical limitation whether you do this or not. And so therefore you can do central resections like this one with reconstructions, or the Appleby resection where you resect the celiac trunk in some cases, but by this you are sure that you do an R0 resection. So while it is agreed on that surgical reevaluation and secondary resection should be performed in locally advanced pancreatic cancer, the extent of resection is still not defined. Radical resection, in my mind, should include artery resection, and I think that's needed to actually come up with a real R0 resection in locally advanced cancer. Thank you very much for your attention.
Okay, excellent. Okay, please.
Thank you so much for your wonderful presentation. So I'm from Nanjing, Professor Miao's group. So in this area of neoadjuvant therapy, so the most intriguing question would be how to identify those patients who are sensitive to a certain regimen of chemotherapy. So could you provide us with some vision on that? Thank you.
Mm-hmm. So do you have some comments?
No, it's
okay. Other questions?
Yes.
Okay, go ahead.
Yes, you think that neoadjuvant is a rather not complicated treatment. Why should we not give it to also those that you think is resectable from the beginning?
You think why we not treat everybody with neoadjuvant treatment?
Yes.
Because you will lose a lot of patients which are primarily resectable and may not be resectable because neoadjuvant treatment is toxic. And especially in older patients, you will come up with some patients who are easily resectable. They have no distant metastasis, but you don't resect because they get sick with the neoadjuvant treatment. But I agree, if we come up with a way to apply neoadjuvant treatment which is effective and is not that toxic, this would be the ideal solution. Of course, because it's a systemic disease. But at the moment, I think resect quickly and then do a good operation without complications and go to adjuvant treatment. Because, of course, you can only cure the disease on the long run when you do chemotherapy and probably do second-line therapy and third-line therapy. It's not the surgery, it's just the basis for potential cure.
Yes, I know that what we're doing today, but still of those 20% that you resect up front, many of them get a recurrence.
Yeah, you will have recurrence if you don't resect locally radical enough.
But I still think that's not enough.
Yes.
I wonder if we can all admit we're guessing. I just want to put that out there because we really don't have good, true biomarkers of who we should do an aggressive multivisceral resection and who we should not.
Yep.
Your thoughts on how we move forward more effectively in this group of patients?
Yeah, you're right. I mean, we do not know whether, sometimes we do over-treatment. That's true for the chemotherapy, that's also true for the surgery. And I think it's a decision you as a surgeon has to do, that you are sure that this patient is going to survive. And then number two, the patient has to agree on the risk he is taking, and you have to actually talk to him honestly what the risk is.
Should all these patients get genomic sequencing? You know, there's data that patients with basal tumors, you know, are less responsive to the therapies we have. Maybe those are patients we shouldn't give neoadjuvant treatment. How about the use of cell-free DNA to kind of mark who should get, for example, adjuvant treatment after neoadjuvant treatment surgery? It seems like we're not deploying all the tools in our disposal to solve this.
Yeah, you're right.
Maybe this way is actually the future direction for the determination of the resectability. Okay, thank you very much, Werner.
Sure.